Let's talk about DIC. DIC is a clinicopathologic syndrome characterized by widespread intravascular fibrin formation in response to excessive blood protease activity that overcomes the natural anticoagulant mechanisms. It can originate from and also cause damage to the microvasculature, which is sufficiently severe and produce multi-organ dysfunction. So coming to the pathophysiology, the underlying disease will release toxins, pro-inflammatory cytokines, which will activate the monocytes and endothelial damage, which will lead to the tissue factor release, which will stimulate the extrinsic pathway of coagulation, and which will lead to uncontrolled thrombin release. There is consumption of platelets and clotting factors leading to bleeding. There is fibrin deposits in the microcirculation will lead to microvascular thrombosis, ischemic organ damage, and multi-organ failure. Microangiopathic hemolytic anemia, secondary fibrinolysis will lead to bleeding and fibrin degradation. Products are released. So, DIC, there is uncontrolled thrombin generation. There is fibrin deposits in the microcirculation, which leads to ischemic tissue damage, will ultimately lead to failure of the multiple organs. Fibrin deposits will also lead to secondary fibrinolysis, which will affect the basal patency, which will cause diffuse bleeding, and there will be increase in the fibrin degradation products. Fibrin deposits will also lead to red blood cell damage and secondary hemolysis. Now, uncontrolled thrombin generation will also lead to consumption of platelets and coagulation factors, which will ultimately lead to diffuse bleeding. The causes of DIC are bacterial that will lead to staphylococci, streptococci, pneumococci, meningococci, and gram-negative bacilli, viral, mycotic, parasitic, and rickettsial organism. Trauma and tissue injury will lead to brain injury, extensive burns, fat embolism, and rhabdomyolysis. Immunologic disorders will lead to like acute hemolytic transfusion reaction, organ or tissue transplant rejection, graft versus host disease. Envenomation like snake and insects, liver disease like fulminant hepatic failure, cirrhosis, fatty liver pregnancy, miscellaneous like shock, acute respiratory distress syndrome, and massive transfusion. Drugs like fibrinolytic agents, aproctentin, warfarin, prothrombin complex concentrate, and amphetamine, vascular disorders like giant hemangiomas, aortic aneurysm, obstetrical complications like abruptio placentae, amniotic fluid embolism, septic abortion, dead fetus, HELLP syndrome, and severe preeclampsia. Cancer like there is adenocarcinoma of pancreas, prostate, and hematologic malignancies. Clinical features related to magnitude of imbalance of hemostasis, the underlying disease, or to both. The most common findings are bleeding ranging from oozing from venipuncture sites, petechiae, and enchymosis, severe hemorrhage from GI tract bleed, lung, and into the CNS. In chronic DIC, the bleeding symptoms are discrete, restricted to skin and mucous surfaces. The hypercoagulability of DIC manifests as occlusion of vessels in the microcirculation and organ failure. Thrombosis of large vessels and cerebral embolism can also occur. Hemodynamic complications and shock are common among patients with acute DIC. The mortality ranges from 30 to greater than 80% depending on the underlying disease, the severity of DIC, and the age of the patient. Diagnosis. The diagnosis of clinically significant DIC is based on presence of clinical and or laboratory abnormalities of coagulation and thrombocytopenia. The laboratory investigation should include coagulation tests like APTT, PT, thrombin type, markers of fibrin degradation products, platelet red cell count, and analysis of blood smear. The test should be repeated over a period of 6 to 8 hours because an initially mild abnormality can change dramatically in patients with severe DIC. There will be prolongation of PT and or APTT, platelet count less than 1 lakh or a rapid decline in platelet numbers, presence of schistocytes and the blood smear and elevated levels of fibrin degradation products. The most sensitive test for DIC is FTP level. DIC is unlikely diagnosis in the presence of normal FTP. Very important. The D-dimer test is more specific for fibrin but not fibrinogen degraded products and indicates that the cross-linked fibrin has been digested by plasma. High-grade DIC is also associated with levels of antithrombin C or plasminogen activity. Chronic DIC, low-grade or compensated DIC, can occur in clinical situations including giant hemangiomas, metastatic carcinoma, or a dead fetus syndrome. Plasma levels of FTP or D-dimers are elevated. APTP for fibrin and fibrinogen values are within normal range or high. Mild thrombocytopenia or normal platelet counts are also common findings. Red cell fragmentation is often detected but at a lower degree than acute DIC. The differential diagnosis between DIC and severe liver disease is challenging and requires serial parameters. The patients with severe liver disease are at increased risk for bleeding and manifest laboratory features including thrombocytopenia, portal hypertension, hypersplenism, decreased synthesis of coagulation factors, natural anticoagulants, elevated levels of FTP due to reduced hepatic clearance. However, in contrast to DIC, these laboratory parameters in liver disease do not change. Microangiopathic disorders such as thrombotic thrombocytopenic purpura present an acute clinical onset of illness accompanied by thrombocytopenia, red cell fragmentation, and multi-organ failure. However, there is no consumption of clotting factors in hyperfibrinolysis. Management of DIC involves three important steps and should be initiated timely and sequentially. Vigorous therapy underlying disorder, energetic treatment of life-threatening complications such as shock, hypoxemia, and acidosis, therapy of DIC per se. When there is no bleeding or venous thromboembolism with only lab parameters deranged, observation without any replacement therapy. Frequent monitoring of blood counts and clotting factors, monitoring of central venous pressure, gas exchange, and electrolyte balance. Prompt treatment of the underlying cause in case of optimal antibiotics in sepsis syndrome, uterine evacuation for abruptio placenta, restoration of hemodynamic stability for hypovolemic shock, anti-snake venom for snake antibiotics. Always IV antibiotics are given, started after taking blood cultures. Outcomes are worse if organism is insensitive to the initial regimen. Component support for platelet transfusion. Platelet count should be maintained around 20 to 30,000 in a bleeding patient. Single donor platelet transfusion. Cryoprecipitate is rich in factor 8, fibrinogen, and monovalent factor. Very important question. 1 to 2 units per 10 kg can be given. Maintain fibrinogen level greater than 100 mg per deciliter. Fresh frozen plasma. It provides all clotting factors and corrects PT and APTT. Dose is 10 to 15 ml per kg every 8 to 12 hourly. Transfusion can be stopped once lab parameters improve. Antithrombin concentrates more effective in presence of hepatic insufficiency. Activated protein concentrates, protecogin alpha, very important. Prothrombin complex concentrates can be given. Heparin is naturally occurring anticoagulant in acute DIC. Heparin can aggravate bleeding. To date, use of heparin in acute DIC has no proven survival. Indication of heparin in DIC is chronic DIC with malignancy, clinical thrombosis like abdominal necrosis, purpura fulminans, acral ischemia, and venous thromboembolism. Retained dead fetus with hypofibrinogenemia, AML M3 prior to conventional chemotherapy. Synthetic inhibitors of thrombin like hirudin, desirudin, vivalirudin, agatroban, malagatran, zimelgatran, and dabigatran can be used in heparin-induced thrombocytopenia when heparin is ineffective in the presence of antithrombin deficiency. Fibrinolysis inhibitors, they block the secondary fibrinolysis that accompanies DIC, tranexamic acid, and epsilon aminocaproic acid prevent fibrin degradation by plasmin and reduce bleeding episodes in patients with confirmed fibrinolysis. Prognosis depends on the underlying disorder. If the condition is self-limiting, prognosis is good. Appropriate and early initiation of antibiotic therapy has a positive impact on the outcome. Prognosis is poor if there is failure to recognize the underlying etiology in case of sepsis, if the organ is insensitive to the initial empirical antibiotic regimen.